Hi, this is Dr. Mahadevan with Dr. Kate Stevens, and we're going to conclude this series on how to read a chest radiograph with part 5. And we're all the way up to G for gastric bubble. When we are looking at, for the gastric bubble, the questions that we have are, is it present? And then if it is present, is it on the correct or left side?
So here we have an example of a chest x-ray, and you're looking specifically for the gastric bubble, and you can see that the patient has gas within the fundus of the stomach, and that's below the left hemidiaphragm, so they have a normal left-sided stomach bubble. The next patient, this is an erect film, and you can see that the gas fills the superior portion of the stomach, and again you can see that the stomach bubble is left-sided in an appropriate position. This patient, you can see that they have a very elongated cardiac silhouette, and their lungs are hyperinflated. Looking below the left hemidiaphragm, you can't see any gas, and so when you look below the right hemidiaphragm, you can now appreciate that the stomach bubble is actually below the right hemidiaphragm. So not only do they have dextrocardia, so the heart shadow is rotated, they also have a right-sided stomach bubble compatible with situs inversus. If we look at the lung fields in this patient as well, you can see these multiple ring shadows all the way through, these coarse ring shadows, some of which, as you can appreciate here, they actually have a fluid level, and this is the appearance of cystic bronchiectasis, such as you'd see in cystic fibrosis patients, but it's a characteristic appearance where you have cystic bronchiectasis and situs inversus, and that's characteristic of a syndrome called Carter-Gayner's syndrome. In this patient, we're looking at the cardiac silhouette, and you can see that it looks enlarged, but we've also got this additional structure that appears to be filled with gas projecting behind the heart, and this is a large hiatal hernia. Often you can see fluid levels within these, but this is a very large gastric hernia. Another patient with a small hiatal hernia, again you can see this gas within a hiatal hernia sitting behind the heart, and you can see here that they have a fluid level within, so a much smaller hiatal hernia, and the gas that you're seeing here is probably within the colon of the splenic flexure rather than a stomach bubble.
After looking at the gastric bubble, the next step would be to look at the hilum, specifically at the hilar lymph nodes and the great vessels, and our questions when evaluating the hilum are, is there an increase in hilar lymphadenopathy, and are there any signs of pulmonary hypertension? And again, anatomically, when looking at the hilum, the structures that you're going to be interested in are the main pulmonary artery, which is denoted here, and that's going to branch off into both the right pulmonary artery and the left pulmonary arteries, and you can see that occurs right here. And it's very important to evaluate these structures, not only the presence of these structures, but also the size of these structures.
So in this patient, again, we're going to start by looking to see if the trachea is midline. And you can see here that the trachea is shifted a little bit over to your left. And you can see that there's increased soft tissue in the right paratracheal region. And so that's concerning for lymph nodes, extra lymph nodes in here. It's far too wide. When we actually look at the hilar region, here we can see the aortic arch, and we should normally have a nice little recess, the aortopulmonary window, and you can see here that there's convexity within the aortopulmonary window. So we've completely lost the contour between the aortic arch and the pulmonary artery. And so again, this is very concerning for lymph nodes. So we have lymph nodes within the superior mediastinum, as well as in the left hilar region. The right hilum also appears somewhat enlarged, concerning for lymph nodes. And this patient had lymphoma. In this patient, again, we're going to be looking at the hilar region, and you can see that they have a lobulated contour really at the periphery of the hilum. So you can see these lobulated, increased size lymph nodes in a peripheral distribution. Again, we can see lymph nodes here, little lobulated mass. And so the patient has bilateral lymphadenopathy, and this was a patient with sarcoid. This patient, again, we're going to be looking closely at the left hilar region, and the patient had a cough, and we're following down from the aortic contour, and so we can see the aortopulmonary window here, but you can see that there's this irregular mass which really doesn't look like the pulmonary artery coming down here. And so in this patient, the lateral view was very helpful. And on the lateral view, you can see this large irregular mass here. So I'm just going to outline the mass for you. And this was a large lung cancer, which was very difficult to appreciate on the frontal view, simply because it was projecting over the hilum. So the mass was largely sitting behind the heart and made it very difficult to visualize. But again, this hilum is enlarged, and that was because they had a mass sitting behind that. In this patient, you can see that the patient has a PICC line in. The heart size is within normal limits. But when we look at the size of the pulmonary arteries coming down, those are increased in size. So these clearly measure more than 1.6 centimeters in diameter. And this was a patient with pulmonary artery hypertension.
Where do you measure from? Can you show us on the X-ray?
Well, whenever you can, you try to measure them when you can clearly see both margins. So you can just measure in a transverse dimension, usually measure it just close to the hilum, because obviously as they go more distally and start to branch, they're going to be smaller. So you really want to be measuring the main pulmonary arteries.
Great. The next step is to look for any invasive devices, such as medical devices like endotracheal tubes, nasogastric tubes, chest tubes, or other devices, and also foreign bodies that might appear on the X-ray. And again, the questions that we have are these devices present? And equally important, are they in the correct position or location? Because sometimes they may be in an abnormal location. So let's take a look at some examples.
So again, a patient is sitting there on a trauma board, and you can see that the endotracheal tube is clearly, heading off in the region of the right main stem bronchus. However, we did see this before, that the patient has a very large gas-filled stomach bubble. So it makes it very suspicious that this is actually within the esophagus and not within the bronchus.
So this is an esophageal intubation.
In this patient, the endotracheal tube is in a good position. You can end up seeing the nasogastric tube, which is also nicely positioned within the stomach. Patient has multiple rib fractures. We saw this patient before, and they have a lot of subcutaneous emphysema, so it's highly likely that that patient is going to have a pneumothorax. And so a chest drain was inserted, and you can see a chest drain here looks a little bit low, but it's okay. Sometimes it can sort of drop back into the posterior costophrenic recess. However, this one is actually directed inferiorly, and this had gone through the diaphragm and had actually punctured the spleen, which is obviously not an ideal position for a chest tube.
So in this X-ray, we've got 3 invasive devices. We've got the endotracheal tube, we've got the nasogastric tube, and we have the chest tube. 3 different devices, invasive devices, and we're responsible again to make sure that they're all in the correct position. And 2 of them are, but 1 of them clearly is in the wrong position.
So this patient has a pacemaker device, so you can see that the 2 main pacing leads pass in a satisfactory direction, but they also had one of these automatic implantable defibrillator devices, so you can see that they're they have a slightly thicker appearance here, and this is a defibrillator device, which would normally pass along the same path as the other leads. And you can see this one actually goes into the aorta and passes through the aorta into the left side of the heart. And again, this is not obviously an optimal position for actually defibrillating a patient, so unusual appearance there. In this case, patient again is intubated, so we can see that the endotracheal tube is in a good position. Patient also has a nasogastric tube, and we would normally expect the nasogastric tube to pass down and then to be seen in the body of the stomach. But when you look carefully at the airways, this closely follows the line of the left main bronchus, and actually this nasogastric tube is coiled within the lung and not actually within the stomach, which is where it was intended. And obviously in this example, you wouldn't want to put anything down the nasogastric tube, which could be disastrous. You can also see that there's differing radiodensities in the lungs. So you can see the hazy density on the right, and you can see very lucent areas of lung. And so almost certainly this patient has an associated pneumothorax where it's ruptured out from the bronchus and is lying within the pleural cavity.
And the final part of our ABCs are S for soft tissues. And what are we looking for? We're looking at the extrathoracic soft tissues as well as the breast shadows if it's a female patient. And the questions that we have are, is there subcutaneous emphysema, or is there an abnormality of the breast?
So in this patient, you can see the right breast shadow down here, and you can see that there's normal soft tissue density within the patient's axillary region, but you can't appreciate a breast shadow on this side. You've also lost the soft tissues here, and the patient has some surgical clips in her axilla, so the patient has had a mastectomy on this side. The patient also has a tunneled port, so the patient is almost certainly getting some form of chemotherapy. So we can see that the heart is a little bit enlarged in this patient, and you can also see nicely that they have blunting of the costophrenic angles bilaterally, so the patient has bilateral pleural effusions. If they then go on to look at the bony structures, you can appreciate that there are lots of little sclerotic lesions almost everywhere you look within the bones. You can see if you're looking at the ribs along here, here's a sclerotic lesion. And you can also see, patchy areas. Again, here we have some more sclerotic lesions. And so this patient also has diffuse bony metastatic disease, predominantly small areas of sclerosis within the bones. So it's important to be able to spot if the patient's had breast surgery, and you can also appreciate once someone has had a mastectomy that the lung field on that side looks a little bit more lucent, because obviously you don't have so much overlying soft tissue, and so that's why this looks a little bit more lucent. And it's good to pick that up early on because it makes you look at the film differently, and you're looking specifically at bones to see if they have any bony metastatic disease.
So a whole host of abnormalities on this chest X-ray, and without a symptomatic or systematic approach like the ABCs, you could easily miss some of these very subtle findings.
So in this patient, the patient again is on a trauma board. You can see that they're on a trauma board, and so you're looking around the margins of the film, and when you're looking along the right lateral chest wall, can you see these small areas of lucency outside the chest wall, indicative of subcutaneous emphysema? So you're then going to look very carefully at the bones, and now you can see that the patient has rib fractures, has multiple rib fractures, and so whenever you see rib fractures and subcutaneous emphysema, you're going to look very carefully for a pneumothorax. You may not necessarily be able to see it on a supine view, and in this patient we cannot see the deep sulcus where we would expect gas down here. But this is a kind of patient we definitely would do an erect film to see if you then see gas tracking along to the apex. So anytime you see subcutaneous emphysema and rib fractures, have a very high suspicion of a pneumothorax. This patient, again, we're seeing subcutaneous emphysema along here, and the patient has now had a chest tube in. And again, we're going to look to see what was responsible for the pneumothorax, and you can appreciate a displaced rib fracture here. So again, look very carefully for rib fractures in these patients.